Lovely, thank you very much. It's lovely to see so many of you here today. We're going to talk about insulin, and the issue we have with starting people on insulin is that we're not very keen on doing it. We have to talk about our patients, and I think we've had some good sessions already today looking at the way we talk with our patients, finding out what do they actually know, how much of the insulin, how much about their diabetes do they know. But we also need to look at motivational interviewing as well, and how can we get them to move on with their diabetes and the medication that's right for them. So the poor patient, he doesn't want to go on insulin. Now, if you all say, how many of us want to go and have an injection? We don't. If we are told we've got to go and have a flu vaccination, I think at the hospital we were bribed with a Subway. If you go and have your injection, you can have a Subway for lunch. We're not keen on doing injections because it's going to hurt. And I think, with the new needles, it's a lot better and it doesn't hurt as much as it used to. So it is a lot better. But the patient thinks my diabetes has got worse. He's going to put weight on. And he's failed. And I think this is the big thing. Patients feel that they've failed with their diabetes. And this is maybe where we need to start the conversation much earlier on with our patients, that it's not about failure, it's a progressive disease, and that one day they're likely to need insulin. But this I come across with a lot of my patients is that, my family member went on insulin and they died. And that is a big issue. And often it's because we put people on insulin too late. We need to start people on insulin a lot earlier with their management. So they're worried about that they've died, or they've gone on dialysis, they've lost a limb, and it's because of the insulin. So it's really about dispelling the myths that are there. They're worried that their life's going to be not so flexible. They're not going to be able to manage. They're not going to be able to go out. They're not going to be able to eat out. They can't go to the church. They can't go to their meetings. So again, these are things that we need to discuss with our patients. They don't want to have hypos. They've heard about those hypos, and we heard Stephanie talk earlier about them. No, sorry, it wasn't Stephanie, it was Harpreet talk earlier about the hypos. And they're a big issue for patients. They worry about it. And then they're not confident. We've already heard today about how much does our patients understand about their diabetes? How much do they understand about their insulin and how they're going to manage with it? But we then have our issues as well. And I've got GPs, but that's the nurses, it's all the healthcare workers. We all have issues about starting people on insulin. And I do quite a few teaching sessions, and we go, right, let's get into groups and let's think about what this how we're going to start this patient on insulin and what insulin we're going to start on. Well, we have half an hour discussion about, we're going to do the lifestyle, we're going to do the drugs, we're going to do this, we're going to do that. And at the end of it, I'm saying, no, we're going to put them on insulin. We're reluctant. We don't want to put this patient on insulin. Okay, we have to get everything else right, but we're reluctant to do it. And a lot of this is about, the patient's not compliant. They're not taking their tablets. So why are we going to put them on insulin? Because they won't take their insulin either. Some of us are just not interested in diabetes. Diabetes is complex. If you remember back to your training and you're thinking, there's type 1, there's type 2, there's different insulins, there's different tablets, and now we've got all those new drugs. Rinky was talking to us about those SGLT2s, the GPL1s. It's taken me a long time to understand them. So, you sit there with a patient and you try and explain to them, what does a DPP-4 inhibitor and how does it work? It's really complex. I haven't worked that out yet. I'm saying to my patients, we've got some new drugs and they might work. But, it's really complex. We need time. When we saw Sue doing the role play earlier on, how many of us have time in our clinics to sit with our patients and actually discuss with them? And it's going to be great because we've got some speakers after us that's going to talk to us about the different ways that we can talk with our patients and using health coaches, which I've been very fortunate to have health coaches, and it's really great to have somebody else that can help and somebody else that the patients can understand what's going on with their diabetes. We're quite complex people. We understand a lot, but if I have to go and look at my car, I don't know how it works. If I have to open the bonnet, I'm not sure I can do that. And that's the same with our patients. They don't really know what's going on. So we need more time for our patients. But we're also concerned about their comorbidities. We're concerned that they've got kidney damage or that they're losing their eyesight, or maybe they're forgetting things a bit. So we're not really wanting to put them on insulin because it's a bit complex. We have barriers in our workplace. You know, we've had CCM, we've had at-risk patients, we've got, I can't remember what we've got at the moment, I think that one's just gone as well. We've got lots of things that have changed, and we've had funding for this and we've had funding for that, and we probably haven't got any funding at the moment, or at least we hope we have, but they are barriers to us to see our patients. So we need to look at that and see what do we want to do with our patients. We've got to look at our resources. What skills have we got in our team? Who's there that can help us? You know, if we've got our, you know, as a GP, you are seeing the patient, have you got your staff around you that can help and support you, that you can say, yes, this patient needs to go on insulin. Have I got somebody there that can take them through the process? Have we got a good chemist? Have we got a good pharmacist that's going to make sure we've got the right stuff going out? We're worrying about hypos for that patient. What's going to happen when they get in the car and they drive? I had a patient the other day who's a crane driver and he's having problems, and I'm going, oh my God. I imagine he's up in a crane and he's on insulin. What's going to happen? These are things we need to think about. We're also worried about these patients, but particularly I'm looking at our type 2 patients here that are already overweight. We've tried them on the medication, they're 150 kg, and we're now going to put them on insulin, they're going to put more weight on. So we have all these concerns, and we're not quite sure what to do with it. We know diabetes is a progressive journey. You know, we know it starts with diet and lifestyle. And it's really hard for us to imagine that this is going to end up, that it's not failure of the patient, it's that pancreas that's failing, and that we need to help and support it. Lifestyle is the most important thing here. We need to get weight off. If you get the weight off, and I think somebody's talking about the direct study later on, which really shows us if we can get weight off right at the beginning of this journey, we can actually prevent this diabetes happening. Maybe we don't stop it happening forever, but if we can stop it till people in their late 60s, 70s, it's a much better place than in their 30s and 40s. But we know that we're going to be on tablets. We know we're going to have to start a lot of our patients on insulin, and then we need to up-titrate that insulin. You know, 10 units of insulin on a patient who's 150 kg is not going to work. You know, we've got to make sure we increase that insulin. So these guidelines are in the New Zealand guidelines group. The documents, I think 2012, it's a little old. They haven't actually been updated because the group doesn't belong anymore. But really, we need to be starting people on insulin when their HbA1c is an unsatisfactory level for that patient. And so it's a matter of making sure that we're looking at patients and individual patients. But we need to make sure that we've done that lifestyle stuff, we've done the exercise, we've looked at behavior strategies. You know, how often are you missing your medication? You know, how many sugars are you having in that cup of tea? Now, those are the questions we need to look at, and whether they're managing their medication that they're on already. This little picture here is a really good picture. Now, you can get it off the NZSSD website. It's so good. You say to a patient, your HbA1c is 80. What does that mean? For them, it doesn't mean anything. But if you've got a chart like this, you can actually show them. They can actually see. You don't actually have to say it's too high, because they can see straight away that it's much too high. So it's really good to have good resources around. We need to make sure that the patient is ready to start on insulin. And it's about that partnership that we've got to have with our patients, having that conversation and discussing it. And I'm sure you've all had that conversation. I'm going to try better this time. I'm going to try to take my tablets. I'm going to try and be good with my diet. I don't want to go on insulin. So I often talk about with my patients, let's have an agreement. Let's have some goal setting here. If things aren't any better in 3 months, then you'll decide to go on insulin. And they go, yes. So and document that. Document it in your notes that you've discussed this, and that next time they come and that HbA1c is still no better, we're going to start on some insulin, so that they come ready to go on insulin. We need to have that blood glucose monitoring done. If you haven't got any readings, you don't know what's going on with the patient. And then you don't really know which insulin we're going to start them on. And it's about getting the patient to take an active role in the management of their diabetes. But we do need to seek specialist advice. So I work in a GP practice in Otara, so it's really on the ground there. But I also work at Middlemore with the secondary services. So sometimes we need to be sending our patients off to secondary service if they just don't quite fit the bill. You know, we're almost like detectives. If things aren't quite right, and you're thinking, no, this isn't the normal kind of diabetes I'm seeing, refer them on. Now, I think they're getting thousands of referrals at counties. It's huge numbers that are coming in. So a lot of the stuff that's being done now is on a virtual review. So a lot of the secondary care will have a look at the letter you sent in, have a look at the results, have a look at what you're doing. And if they think, no, you can manage this yourselves, they will send back some ideas. So, you know, it's like getting a little bit of advice from somebody else. But equally, you can ring up and ask, you know, ask to speak to somebody with diabetes. The registrar's on duty there. The nurses are around. You can ask for help and they can give you some advice over the phone. But which insulin? You know, are we going to do it once a day, twice a day, 3 times a day? Which one? When at lunchtime, you've got all 3 drug insulin companies out there. Go and have a chat with them. Go and have a look at the resources they've got. Really have a look at the information, because it's really good to have a look and see what's going to be right for your patient, because one size doesn't fit all. You know, some patients aren't going to manage with multiple injections. Some might manage with 1 a day. So have a look and see what's happening with their food. A lot of my patients eat a large evening meal, so that one particular insulin would work better for them. But our patients live unpredictable lives. They have different eating patterns, they have different working hours, their working shifts. The shifts are different from whatever we used to think they were. We've got different ages. So we might have somebody in their 30s, but we might have somebody who's 80 years old. Think about the person. These diagrams are really good because it can actually make you think about the insulins. When we think about what insulin, well, how does the insulin work? What are you trying to do with that? So you've got your really fast-acting insulins, you've got your regular insulins, you've got your medium-acting, and then you've got your longer-acting ones. There's some good charts upstairs. Go and have a look. Go and take some charts. Get them up there. Big thing is, get used to one of the insulins and think, yeah, I'm happy with this one. I know how it works. I know when it should be given. And I think, you know, the poor patient we heard talking earlier on about, you know, the tablets they had said take 1 in the morning and 1 in the evening. You know, it's the same sometimes with insulin. It's put down, it says take it in the evening. Well, what does that mean? Is it with meals? Is it at bedtime? You know, we need to be very specific with our patients about what we mean and what we want them to have. So quickly over the blood testing, we need to talk to our patients about when to test, how to record it. You know, it's lovely when a patient comes in with a book, but ask them, because sometimes people bring their books, but they don't get them out because nobody's asked them. So, and say to them, bring your book with you every time you come. Bring your meter with you, because when you look at your meter, you can see, have they used the meter? You can recheck the results. You can check that the strips are in date, because often the strips are out of date and then the results don't mean anything. So this gives you a good idea of what's going on with the patient. You need to have a look and see about their hypos, because often people will say, I'm having hypos, but have they tested? Do they actually know it's a hypo? Or is it just that their blood sugar is a bit better than it has been in the past? So it's really good to find out a bit more information. Injection technique. Again, we need to talk to our patients about how to inject. And I think, you know, the funny video we saw with the patient doing this with their puffer. Well, the patients do it with their insulin because we've shown them how to dial the insulin up, and you go, oh, and then you just press the button like this and the insulins come out. We need to make sure we've actually given the injection with the patient, get them to do it, because then they understand it. You know, just dialing things up and squirting things out doesn't work for our patients. Look, ask the patient, ask them, where do you inject? Have a look, get them to lift up their clothing, have a look, have a feel to see whether they've got lumps or bumps, because a lot of our patients will have, and then consequently, the insulin's not going to work very well. But if you don't ask, you don't know. And a lot of patients don't necessarily give their injections. So, if you look, they might think, oh, I better do it next time because the nurse is going to ask me or the doctor's going to ask me. They don't want to disappoint you, so they will do it for you, but do ask them. So, what do we start them on? Well, the guidelines suggest that maybe a long-acting insulin like Protofane or Lantus in the evening is really good. It's a good way of starting our patients on once a day. And depending on, if you go back to that picture which shows the way the insulin works, depends on which one you're likely to want. I actually quite like the premix insulins because a lot of my patients eat a large evening meal and that I find that the long-acting insulin is just not going to cover it. So starting them on a premix insulin with their evening meal is quite a good way of starting as well. So everyone will have their own ideas. So if we all asked you all, you'd all probably have a different idea of what insulin. As long as you've got a rational decision about why you've started them on that insulin and what it's going to work for that patient. So when we're starting them on insulin, it's not a quick, easy thing. So we need to make sure that they know how to test their blood sugars, they know how to give their insulin injections, they know where they've got to give it, when to give their insulin, how to store it. If the patient's bringing you, I had a patient on Thursday came in with their insulin, so they had their pen, then they had their cartridge in a box. Well, the insulin wasn't cold, so I knew they weren't keeping it in the fridge. So, if it's not kept in the fridge, it's going to go off, it's not going to work. So it's little things like this that we just need to keep asking our patients, where do they store it? Now, the insulin they're using is quite stable out of the fridge for a month, so it's fine as long as it doesn't get too hot. So we need to talk with our patients about this. And how the insulin works. Pen and drawing and putting up all those little ups and downs on graphs is really good because it helps the patient to understand it. Where do they get their insulin from? Where do they get their pens from? Where do they get their needles from? How do they get rid of their needles? How to treat a hypo? How do they know they've got to put the insulin up? Do they want a medical alert? Who do they contact, when you've gone home from work and there's no one there when they've got a problem? So all these things we need to discuss and make sure that they go away with. Now, you can imagine you've got your patient in front of you and you give them all this information. It's going to go in here and go out there. So sometimes we have to do this slowly and let's go through it and make sure the patient, ask them back, that question, how much do you understand? Do you know where to get this from? Needle size. It's really important, as I said about that, needles hurt. So that 12 mil, we were really excited when we had the 12 mils. It was, these are really good little needles. They don't work anymore on our pens, all right, because they won't fit on, the lids can't go back on. Do not prescribe them, okay? So what we're really after is probably about a 5 or 6, and it doesn't matter the size of the patient, those are the best needles for your patient. So you've got the different colours there, you can see with the BD ones. So I think it's the pink ones we don't want, the 12 mil ones. We need to get the patients to change their needles. You show the patient how to start the insulin, you put the needle on, and that needle stays on, and patients forget that they need to change it. But as you can see from here, you've got that, the brand new needle has got a little coating on it, so it goes in nice and smoothly and it doesn't hurt. But as you can see, when they've been reused, that they get little hooks on them, and they're going to hurt. So we need to get our patients to change them. Now, Pharmac has just actually agreed on getting more needles. So we really should be able to give our patients as many needles as they need. I would, it depends on how often they're doing an injection. I usually say if they're doing once a day, probably maybe 2 or 3 times, use that needle and then change it. If they're doing 2 or 3 injections a day, change it every day. And really, it's about comfort for the patient. So let's get them to change them as many times as they really need to, so it's more comfortable for them. Because it will cause these lumps. So injecting in the same place all the time, you're going to get the lumps. With those needles, it's going to hurt. So let's get them to change them as much as they need to. And also with those lumps, the insulin doesn't work very well. So, you think you're giving the right dose and they're going to get high sugars or they're going to get low sugars, and a lot of it is because they've got lumps and bumps. So if we're starting them on a long-acting insulin, we need to really look at their fasting blood glucose, because that's what we're aiming to target, to get the fasting blood sugars as best as you can, because then they're going to start off the day with a much better blood sugar. So if that one is raised, we keep pushing the insulin up. And I usually suggest you push it up a couple of units I've got 4 to 5 days, but you might do it more often depending. Write it in their book, write it in that record book, because then the patient can actually understand and see where it is. If you want them to ring back, that's great, but a lot of our patients won't ring back, and it's not easy for them. So you want to say, look, I want you to come back and see me in a few weeks' time. Let's increase the insulin slowly over this time, depending on what your blood sugars are like, and then when you come back, the insulin's gone up. If they're on a long-acting insulin, we continue on the metformin and the sulfonylureas, because they're still working. Now, sulfonylureas, we roughly think we're going to stop working maybe after 5 years, definitely after 10 years of diagnosis of diabetes on a sulfonylurea. The pancreas is not working, and so really we need to be thinking really of adding in a mixed insulin or adding in some short-acting. And this is where those new drugs that Rinky was talking about, really we should be using a second line, because they're not going to exhaust that pancreas, because sulfonylurea is going to exhaust that pancreas. Even though they work really well, we know that they're heading towards insulin at this point. If we're going to start them on a mixed insulin, it tends to be people who are having high sugars after they've eaten. So, when you eat your food, so we've all just had some lovely muffins, our blood sugars have gone up, they should be coming back down to normal by the time we get to lunchtime. But somebody with diabetes, it's not happening. Their blood sugars will stay high, and they're going to need some short-acting insulin there. A lot of us are eating too many carbohydrates. And I think a lot of our patients are eating a lot of carbohydrates. And again, that's going back to that conversation. And we've got Teresa talking this afternoon about diet. And it's really identifying those carbs and trying to cut them down so we're not eating so many. But again, what we do with this is we start them on a small dose of insulin with their evening meal. And this is quite good because it links the insulin with the food. And that's what you want to be doing. And you then want to be checking their blood sugars either before bed or first thing in the morning to give you an idea of what's going on. When you start them on a mixed insulin or a short-acting insulin, we tend to start stopping the sulfonylureas. It's another option with our patients. Our patients are saying to us they've got too many tablets. So if we can start reducing some of their tablets, they might be more acceptable to go on insulin. So again, it's that conversation that's worth having. If once-a-day insulin doesn't work, we need to change it to a different type or add something else in. As I said, think about pre-mixed. Discuss with the patients what's right for them. We need to increase the insulin. Don't just leave it as it is. We need to look at the patient's meters. We need to look at their result books. We need to also look at their lifestyle, their diet, exercise, and how they're managing. Ask the question, how often are you forgetting to do your insulin, or how often are you forgetting to do your tablets? Right, those are really important questions to ask our patients. Okay, so it might be that we're doing 4 times a day, we might be doing twice a day, we might be doing once a day. It's about getting patients started and then progressing to what's right for our patients. It's finding the right thing for our patients. Now, this week actually is Insulin Safety Week. So it's really important that we look at this. There are huge issues with giving insulin and getting the right insulin. So this is actually a poster that's going in the hospital, and we're trying to make sure that first of all, we've got the right patient, the right insulin, the right dose, the right device. So those are the pens. So go and have a look at the pens. You've got to get the right pen to go with the right insulin, the right way and the right time. It's really important that we get this right. Now, this is a photo from a colleague of mine, but her patient was taking her insulin every day. Like, our patients are very good. And she said, I'm taking my insulin. I really feel unwell after I've taken it. And this was a picture that she took. Does anyone know what's wrong with this? Both insulins are short-acting insulin. Okay, so she was taking double dose of short-acting insulin and going hypo. So look at the names of your insulins, all right? They're very similar. Clear insulin, These two are clear insulins, they're short-acting. Be wary though, Lantus is a clear insulin as well. But, you know, it's just been about wariness, about what they've got. And that's why it's so good to get their insulin out, have a look at it, see what's going on. You've got your health pathways, really good. Make good use of them, okay? There's some good BPAC stuff out there. Go and have a look at the BPAC information. And I just want to plug an event that we've got coming up in July. We're going to have a summit in South Auckland around diabetes and the issues that we're having. I was part of a huge audit that we've had over the last 25 years with GP practices, and we're going to be publicising all the information. So we will be sending this out and advertising it, and we're going to get a lot of people involved with this, so do look out for that. And the other thing is that I'm working with Rinky on the Worth study. So I've got little flyers here that you can stick on your computer to look at the patients that are eligible. I'll be around at lunchtime, come and see me. And my colleague, Rebecca, would you like to stand up? Rebecca's a GP from down near Taupo, and she's working with us. So the pair of us will be there at lunchtime. Come and see us and pick up a little thing here, because we need our 300 patients. And the wonderful thing I think about this study, it's for Pacific people and Maori. These are studies that have not been done. We need to see which of these drugs are going to be right for our patient. Thank you very much.